On the hour, right?
Yes. Welcome to today's New England HIMSS COVID webinar, COVID-19 may have just saved U.S. healthcare, presented by Esmond Kane, Chief Information Security Officer of Steward Healthcare, and Richard Stainings, Chief Security Strategist for Silera. All lines have been muted upon entry. Please send all questions via the chat feature, and we will answer them at the end of today's session. Esmond Kane currently serves as the Chief Information Security Officer at Steward Healthcare, a 35-hospital, multi-state healthcare conglomerate that provides world-class care to more than 2 million patients annually. In his role at Steward, Esmond's focus has been on transforming Steward's approach to information security, threat and risk management to comply with industry frameworks, regulations, and best practices. Richard Stainings is a globally renowned thought leader, author, public speaker, and advocate for improved cybersecurity across the healthcare and life sciences industry. He has served on government committees of inquiries into some of the worst healthcare cybersecurity breaches. He has also been a board member of the Association for Executives in Healthcare Information Security and has served on the International HIMSS Privacy and Security Committee. Please join me in welcoming Esmond and Richard today.
Good morning, and thank you very much for joining us today. Esmond, a few words, disclaimers perhaps.
Yeah, just as a cautionary tale, folks, the opinions and the sentiment expressed today represent that of the personal speakers, not necessarily of our associated organizations. We're not going to discuss anything confidential, nor should anything be inferred based upon the information you hear today. But thank you for your time. Thank you for all of your hard work throughout this COVID emergency. We hope that the model we present today is interesting, intriguing. We look forward to your questions.
Perfect. Thank you very much. Let's start with a quote, a Chinese quote here called Wei Ji, if I pronounce that right. It's essentially is Chinese for crisis, and never let a good crisis go to waste. The characters Wei Ji stand for danger and opportunity, and I think there's a lesson to be drawn there in our discussions today about how we can see, how we can take the bright side of this COVID pandemic that all of us are working around the clock to deal with currently, and to take some meaningful lessons from it. One thing in essence is that COVID has jarred us out of our safety nets, out of our happy spot, as it were, and caused us to rethink a lot of what we do in a more constructive manner, right? Healthcare is highly regulated, very conservative, and largely regarded as being unadventurous. We don't tend to think outside of the box. We tend to think within the regulatory frameworks that we're constrained by, and the financial frameworks that we're restrained by. We need to think of new innovative ways of treating patients when we're dealing with COVID emergency, and I think there are a lot of lessons that can be drawn from that. Healthcare is in a bit of a crosshairs at the moment for many reasons. Rising delivery costs and declining revenues have threatened the very future of many smaller rural hospitals. And I'm sure many of you on this call today will have read various articles in social media and in the healthcare press talking about the borderline economic feasibility of a lot of hospital systems today, particularly those that are in rural establishments that were pretty marginal to start with, that are being pushed right to the edge, given the fact that nearly all elective procedures have been cancelled or postponed, and that most of us are in an emergency operative manner. We need to get a lot smarter about how we deliver medical services, and I think that COVID has provided an ideal opportunity for us to perhaps speed up some of the things that we've been discussing across the industry. Certainly within HIMSS over the last few years around increased digitalization of US healthcare systems, and to take advantage of new technologies. Esmond, over to you.
So as Richard indicated there, healthcare is a system. It's a collection of not just business processes and IT systems, but also a lot of devices and a lot of workload associated with those practices. We've had to pivot a lot of that as a result of the COVID crisis to transform and accelerate a lot of that IT delivery. But this idea of pivoting those systems, keeping an eye on the vision, we've had to be a lot more tactical. So the goal here with today's presentation is to talk about what opportunity exists in that chaos, to talk about how we can walk back some of these expedient measures we've taken, but also talk about what opportunity exists to align the business practices with more of that IT functionality. Now that we have accelerated some of those deliveries associated with things like the HITECH Act, what does it look like in the post-pandemic world? What measures did we take that we need to continue? What measures can we talk about that we need to actually reverse? So hopefully you guys will learn a lot from today's talk. Let's move on with the slides. Thank you.
Perfect. So most of us that have been in this industry for some time have noticed that some things have changed, but very little has. We've inherited a legacy healthcare system that really has its roots are formed back in the 1940s in the US when GIs came back from a war in Asia and in Europe. And we are still dealing with the legacy aspects of that particular model. Of course, back in the 1940s, it was largely palliative care model, and we've moved to a highly interventionist model of care, but seemingly passing by public health and population health concerns, which if we look at other OECD countries, they have tended to focus a lot more heavily on public health concerns and the overall population health of the population. In the US, we have some of the highest levels of obesity, diabetes, malnutrition, hypertension, stroke, and heart disease. Each is extremely expensive to treat. And these are reflected in, some of the statistics that we're going to share with you in a minute, that, 75% of the money that we spend on healthcare across the United States goes to treat these largely preventable chronic diseases. I put a chart up here from centers from CMS that talks about US healthcare costs and how they have increased drastically compared to GDP growth in the US. The US has had a very, very high and fairly sustained GDP growth since the Second World War, and yet our healthcare costs have outstripped that GDP growth year over year throughout most of that period. Our costs are widely regarded internationally as being out of control, and we face a very real crisis in that with a silver tsunami of baby boomers retiring and all hitting Medicare over the next 20 years, or 15 years, then the US health system is going to be placed into increased challenges in terms of financing, paying, and providing the health services that are required in order to meet our aging population. We also have some of the worst healthcare outcomes of many developing nations in the OECD countries. We spend twice that of other countries to provide the health services in the United States, and some obviously elective procedures that we do, or innovative procedures that various hospital systems in the US do, are right out there. They're cutting edge. But by and large, overall, for the population, our healthcare outcomes are worse or no better than countries that spend half the amount or less than we do in the US. The chart you see in front of you talks about infant mortality rates. And if you can see here, the two blue boxes, and hopefully this is a bit of an eye chart here, so hopefully those of you who are on small screens can actually see this. You'll see there's a range here from New Hampshire and Vermont on the left-hand side here at the lower end, just below 4 on the deaths per thousand, right the way up to 9 up in Mississippi in terms of infant mortality rates. This tends to suggest that you have a higher chance of your infant dying if you live in Mississippi than you do in somewhere like Chile. And there are a number of other countries that fit in within that range that are not on this chart, some of which are from developing countries. And this, to me, says a fairly good message that our healthcare system in the US does not include or does not cater for the entire population. And we do a good job at some things and a bad job at other things. If we look at maternal mortality rates, The state of Texas has a higher maternal mortality rate than many Latin American countries. Now, there are a lot of reasons behind that, including nutrition and social well-being and access to healthcare being some of the major factors there. But as a country, we're not doing very well on some of these statistics. The question is, has technology, and the US has some of the best healthcare technology in the world, has it changed our healthcare for the better? Has it changed processes inadvertently? Which came first, the chicken or the egg, as I say here? The applications that we select greatly influence our clinical workflows. And I've been involved through my 25 years in healthcare with a number of EMR rollouts, as I suspect many of you on the phone have been. And it's not something I would readily volunteer for again. But one of the big issues is that we change our clinical processes, our clinical workflows, in order to fit the technology that we have procured, or we spend a vast amounts of money to change the clinical workflows in the technology in order to fit the practices that our doctors and nurses and other clinicians follow in order to provide care to patients. The big question is, it has driven great advances in medicine and patient outcomes, but at a cost. And has that cost detracted from overall population health, or has it had some other positive impact?
Turn off the sound.
We're solving the.
Someone must be unmuted.
Okay.
Richard, sorry, I'm trying to figure out who it is.
Yeah. So how did you end it with Shantanu? What was your?
You're still unmuted. Okay.
Yes, I'm not sure who it is. I can't see who's unmuted. Everybody appears to be muted except you and Esmond, so I'll keep looking.
No problem. Sorry for that interruption. So life expectancy has steadily increased since World War II. And if we can see here at the chart at the left-hand side, you can see that the US has made some great gains since the 1960s in terms of longevity. But what this chart doesn't show you is that there are many countries that have much, much higher life expectancy than the United States. Obviously, Japan is top of that list. And if you happen to reside in Japan, then your life expectancy is up in the 90s. That may have something to do with diet and the omega-3 rich diet that many Japanese live on. It may have many other factors, including the focus of the Japanese healthcare system. So moving on, in the US, we tend to treat the symptom rather than the cause. And I think there's a good example here in terms of the way that the US mobilized in the post-war era to deal with the pandemic of poliomyelitis. We built iron lungs in order to keep patients alive, and and then eventually got round to dealing with the problem of pandemic disease by widespread vaccination, to the point that we have virtually eradicated polio from the world at this stage, which is great because it's a very debilitating disease that could easily be eradicated. Hopefully we'll be able to do the same with coronaviruses like COVID-19 and many of the other flu pandemics that we've seen over recent years. We tend to use a lot of invasive medical procedures which are very expensive and very selective, obviously. We have out-of-control pharmaceutical prices in the US compared to many other, or most other countries in the world, and yet we spend very little on prevention. In other words, dealing with the well-being, the diet, the exercise, and other social healthcare concerns of our population, or the health of the public as a whole, which raises many questions, right? Chronic disease affects the quality of life. It's also a major driver in the healthcare costs of our system, whether you're on a private company insurance, you're self-paying, or you're on a government-funded healthcare system, and I'll talk more about that in a minute. But it is sucking up a large amount of resources to deal with chronic disease. 96% or 96 cents on every dollar of Medicare is spent on the treatment of chronic diseases, and that's 83% of Medicaid spending. So we are channeling the vast majority of our healthcare spend, which we all spend a very large amount of money on, incidentally, compared to other countries, on dealing with chronic disease. Many of those chronic diseases could be severely reduced, and 45% of the population suffers from them. The question really becomes is where you combine chronic diseases, where we have MCC on multiple chronic conditions that become extremely expensive to treat. And as I said, much of this is preventable with adequate public health. The Silver Tsunami. So the population is aging. We all know that. And any of you that have been to the major HIMSS conferences over the last 5 years would have probably sat in at least a couple of sessions talking about the Grey Revolution, the Silver Tsunami, or other terms that have been used to apply to the aging population. Older people tend to consume a much greater proportion of healthcare resources because they're sicker as they get older. Most of those elderly people will be on Medicare, even the poor ones eventually. And poor people have more chronic disease. So we may need to spend more money, ironically, on Medicaid for people that are in their 20s and 30s and 40s in order to keep them healthy, so that we're not spending inordinate amounts of money on Medicare when they finally hit 65 and start drawing upon it. Public health, as I said here, is an economic utility. There is a value to me in being healthy and having invested money in my health and well-being and gym membership, and although I'm not able to use that right at the present time, as I'm sure most of you are in the same condition. But there's an economic utility to me for the person that sits next to me on the New York subway or the Boston T, for them to be healthy so that they don't pass a communicable disease to me and make me sick and impact my my overall health and well-being. And at the same time, there's an economic utility to American society by having society as a whole, the population as a whole, healthy, because then resources, scarce healthcare resources, are not being directed at dealing with those individuals that have chronic healthcare conditions. As I said, many of which can be alleviated or remediated through proper care and proper guidance at a younger age in life. We have also in the US tended to focus on cost shifting. We shift costs from government-funded programs like Medicare, Medicaid, and the Indian Health Service to insurance-based systems or insurance-based payments because Medicare, Medicaid, and IHS don't cover the costs of service. My argument here is that we need to get a lot more efficient in terms of delivering those services because the ability to cost shift is declining. Health insurance companies are pushing back on bills that they regard as being overly expensive, and there are general reimbursement rates are declining, not just in government-funded programs, but also in insurance-based programs. So this is something that we all should be looking at and thinking, hang on, we need to think outside of the box here. And I think COVID allows us to do that, right? One issue that's come up fairly recently, and I don't know if you saw my my blog on this last week, as a URL at the bottom here if you want to go check it out. But HHS essentially banned balance billing, or surprise billing as it's often called, where third parties are involved in a procedure, a patient isn't aware of it, doesn't sign off on it, and they suddenly receive a surprise bill for the gap between what the health insurance regarded as fair and adequate payment and what the individual who provided a service was charging for that service. And there's been a lot of politics around this through the House, for those of you who are involved in various HIMSS government committees or other organizations that report on this, around eradicating this process, which is illegal in many states, but still prevalent in many other states. So I think we've reached a point now where we've talked about where the issues are, where the problems are on the current status of healthcare, and let's look to the future. Over to you, Esmond.
Yeah, so Richard, thank you very much for some of those insights. You've just heard some common themes that we'll touch upon throughout the rest of this presentation. things about how software and data is eating the world, how we've had to adapt some of these legacy processes into more of a digital world. And when we think about that increasing interconnection between business process, the patient, and the physician and clinician is where we'll spend the rest of this deck. So the first one is just revisiting this mentality that in a retail world, Amazon has replaced the necessity to go visit a bookstore and soon to be a grocery. We still expect some of our patients, our customers, for lack of a better expression, to show up in some of these big plants. That prevention that Richard talked about is can we get ahead of that? Can we start thinking about capitalizing on the data we're collecting to be more focused on the user experience, prevent users having to show up in these facilities and potentially expose themselves to COVID? Are there things we can work with so that their experience benefits from a mobile application so they can schedule some of these scans and consultations online, if not outright FaceTime or connected directly with a clinician, so that user experience is at their fingertips. It's not necessarily something you're doing in some of these legacy applications. You're picking up a phone, you're calling someone, or they're calling you to remind. What does that look like? And the analogy here is, well, what Amazon did was they destroyed the book business. They destroyed some of those retail centers, and now it shows up on your front door, your front stoop. So the king in his castle is now everywhere. It's much more pervasive. As Richard touched upon there, the future is here. It's just not evenly distributed. What we've just invested in with COVID is very user-focused and something that we can build upon. We can move forward, Richard.
Yeah, so telehealth and telemedicine are a great example of that. And I think many of us that are on the delivery side of healthcare will have recognized that this is something we've been talking about for at least 5 years, probably longer. I remember presenting at a healthcare conference 5 years ago on telehealth and telemedicine. And people were pushing back saying, well, we need to secure it. We need regulations around it. We need the technology to be present so that we can adopt these types of things. We see them as being valuable. We see this as being the future, but we're not ready for it yet. And I think COVID has suddenly thrown us into adopting very quickly to these types of technologies. It's almost impossible to go see your doctor these days. Most physician offices would love to see people, but they're dealing with COVID patients and what have you, right? It's much easier to fire up your laptop or jump on your smartphone and do a video consult with a physician, maybe your personal physician, or maybe someone at a phone bank or a telehealth bank. For many of these companies that have focused in this for going back a couple of years. I was at a conference, speaking at a HIMSS conference in Asia last year, and one of the presenters, a very learned PhD and head of a hospital system in Korea, had done some statistics of his entire staff and many other hospitals that he dealt with, and he came up with the statistic that he can see 4 times as many patients via telehealth consults that he can in person. Thus, the cost of the consults are less than half than office visits, and patients waste considerably less time driving to a physician's office or a hospital in order to see a professional, a healthcare professional. It boosts patient satisfaction scores, which, as we all know, is something that the industry has been striving to improve for many years, and it puts patients at considerably less risk of contracting something contagious while sat in the doctor's office. I, for one, remember when my children were smaller and I'd take them to the physician's office, and they'd have a runny nose or something, but there'd be a couple of people behind them who were cowering to get away from my little kids, who they regarded as germ magnets because they were elderly and concerned about contracting something contagious that, let's face it, most kids school-age kids tend to have. So, this is the future. We have embraced it under telehealth with relaxed OCR regulations around this. Let's put those permanently in place, and let's look at adopting technologies like this and many of the others that we're going to talk about as we move forward. AI, machine learning, and automation are also other factors that are beginning to revolutionize our healthcare system. We're using AI now to enhance contrast tomography scans and various other imagery within healthcare, and that is leading to earlier diagnosis of cancers, tumors, what have you. Less invasive treatments that cost less money for patients, that take them out of the workforce for less time, allow them to recover quickly and to return to their jobs and their roles in family and society, which leads to, of course, increased patient longevity and lower healthcare costs, because expensive expensive surgeries can be avoided by early diagnosis and adoption of treatments. So what does 2025 show for us, Esmond? Or what do we believe is going to happen?
Thank you, Richard. So as Richard just described, we're overcoming some of the obstacles that we have created inherently. High tech created this necessity to converge and make sure a lot of our systems were interoperable. The last mile, that gold standard was to get that in front of our users, and COVID has overcome some of that obstacle. So now we have ubiquitous access potentially to our users. Our users also can connect with us. That connectivity is at its heart about collecting data and making it available and actionable. So in the new post-paradigm of pandemic world, IT is now critical to the delivery of the service. How do we ensure that IT in that world, that security and privacy does not continue to be an afterthought, that our emphasis around functionality isn't at the expense of patient safety? How do we ensure that we're preventing problems? The rate of change, the way we're stitching together these operational technology, these IoT systems, is only going to increase, because that opportunity to take that data and pump it through some of that augmented intelligence or outright analytical opportunity that Richard described is only going to increase, because the patient outcomes are significant. So when we start to monitor patients' heart rates, blood pressures in the home, and we make that available to our EHRs, it also means that we need to accept some level of consumerization. There's going to be an IoT taking over the world, and we'll talk about that in more standards and ways we can overcome some of those obstacles shortly. Richard, can we move on? So the big issue there, as I described, is there's not without some peril to this paradigm that we're adopting. So we're going to have our increased IT delivery. But if you look at some of the statistics, and this is an interesting, it's as much as it's a fun chart, it's not real. You know, the benchmark here is that 93% of all statistics can be made up. When you're looking at software failure here, the very last bar, about 20% of vulnerabilities in most systems are associated with our security. So we've tried to solve problems, and inherently we've actually created harm. We're actually trying, as much as we're overcoming some of our issues, we're also introducing new ones. These health-related devices and equipment, the connection, this relative sophistication we're trying to introduce, this intelligence comes with some downfalls. So about 20% of our systems are associated with actually introducing vulnerabilities. 20% are security flaws. We're trying to stitch together, we're trying to create this business transformation to focus on the value, the gold standard, the patient outcomes, but instead we're actually increasing some of our risks. These consumer devices are certainly a huge element of this when we look at the next step. Richard, if we can move on.
Yeah, absolutely. Yep. So, you know, cybersecurity is becoming the greatest single patient safety risk. In my role, in my various roles in various hats, I've spoken to a large number, thousands of hospital CEOs and ministers of health the various countries around the world. And I ask all of them similar questions. You know, what keeps them up at night? What are their greatest concerns? Obviously, finance is a big concern at the current time, particularly with the COVID crisis, and the safety of their staff, who are on the front lines dealing with highly infectious patients. And you know, we've all unfortunately seen a lot of our nursing staff and physicians that have you know, come down with COVID as a result of their brave treatment of the chronically sick and dying from COVID. But cybersecurity has risen over the last few years as being, you know, a prevalent risk. I ask CEOs, you know, what are the greatest risks? And most of them will probably say, well, patient safety is my number one concern. And that still is the case. But what has happened is that they're no longer concerned quite so much about hospital-borne infections or clinical procedures going wrong, or failures, patients dying under the knife, those sorts of things. They're more concerned about a ransomware attack or a cyber attack that takes out their ER while they're in the middle of operating. And we've all seen stories of, you know, computer systems suddenly decide they're going to download Windows patches and do a reboot in the middle of an operation. You know, there's a lot of horror stories of things like that. But these are things that we need to consider as we move forward. In the past couple of weeks, we have seen a targeting of the healthcare industry globally by cyber criminals, who obviously lack, you know, any form of ethics or morals that we regard as being acceptable, and are targeting largely distracted healthcare systems that aren't able to patch because many of their staff may be furloughed, or many of their IT staff may be working remotely and therefore don't have direct access or the right level of access in order to patch firewalls and gateway devices and VPN servers and all the rest of it. And just down the road from me last week, Parkview Medical Center got hit with a ransomware attack. Their entire EMR system was encrypted. Their backups were all encrypted, and it has taken them from that point to this point to go in and discover what happened on their networks, to clean up and to start to restore from backup tapes all of their medical records. And this is a subject that I've written about. I'm in a blog on yesterday, actually. It was published yesterday, if you're interested in learning more about this. But it's not just the US. It's, you know, a number of medical research centers that are researching COVID and looking for, you know, for prophylactics that can be used in order to stop the spread of the disease or to ease patients that are infected by it, right the way over to, you know, the Czech Republic. The University of Brno in Moravia was hit with a very big ransomware attack, or an attempted ransomware attack, 10 days ago, and was luckily thwarted in time. But you know, this is a growing problem that we need to address. And I think we are gradually beginning to do that, right? By adoption of, you know, the zero trust security model. For those of you who aren't aware of it, you might want to put that on your Google list during your coffee break today. But zero trust essentially is being driven by our response to COVID. Right? We have a lot of staff working from home today, and we have had to lock down their access, so that they have access only to the systems that they need on a need-to-know basis. This is a zero trust principle, right? And at the same time, we're having to do the same for objects, for endpoints, things like medical devices or other healthcare IoT devices in our hospitals that are plainly at risk of being compromised and being used as a foothold to attack the rest of the network. And many of these denial of service attacks or ransomware attacks are using unsecured healthcare IoT or even OT devices in our hospitals, things like elevators, HVAC, power management, water management, these types of systems in our hospitals that by and large also have no security. The fact of the matter is that we have very little idea as to what devices, non-IT devices, we have on our healthcare networks. They far outnumber traditional IT devices today, and they pose probably the single greatest cybersecurity risk to our hospitals, right? And we need to look at zero trust principles like micro-segmentation of hospital networks and locking down those dumb devices that cannot be patched or secured to a need-to-know basis, in the same way that we're locking down users under COVID.
Richard, if I can, you know, the important thing about Richard is stressing is we've extended or augmented our existing network now to include that new workforce that's at home. You know, it's not just our patients, it's also a lot of our workforce. We are subjecting those external users to conditional access controls. Why can't we do that same thing for our internal networks? We're already talking about doing it around IoT and these other more fungible devices that aren't tolerant when it comes to some of our traditional security footprints. You know, take that external workforce and start to treat your internal one as if it was subject to the same constraints. Do that continuous assessment, that continuous validation. Because as Richard's about to speak to, coronavirus is going to be around. It's going to start hitting that seasonal kind of spectrum. Thank you, Richard.
Yeah, good points. Good points, Esmond. You know, we've read in the press, and we've all seen people on TV saying how the economy is going to open up, you know, in the next week or two or whatever. But the fact of the matter is, the coronavirus is going to be like a flu bug. It's going to be around for at least 18 months. We're going to have to deal with it, right? And we're going to have to deal with it in different ways. But I think there are many lasting effects of the current pandemic and work processes that we have regarded as normal, which have now become the new normal. And work from home is probably one of those. I read an article yesterday about Barclays Bank in the UK. They have a massive office in London Docklands that is always absolutely packed, and they're saying now they no longer need the space because most of their staff will continue to work from home at least for the next 18 months, and they don't see the value in keeping that office space. Telehealth and telemedicine we've already spoken about, and how those are probably here to stay. Once people get used to the convenience of it, our patients get used to the convenience of it, they are going to demand it. They're not going to want to drive to the doctor's office or take a T or a bus in the snow to come see some specialist. They're going to say, let's do it via video. Let's do it via Skype or Zoom or whatever other technology we can secure, or WebEx. Of course, we're on a Cisco WebEx right now, so not to forget the wonders of Cisco WebEx. But these types of technologies enable greater access to healthcare, which is a good thing. And they also allow us as practitioners in the healthcare space to provide services much more cost effectively at times when we are being told to do more with less. So it's a double-edged sword that is advantageous to us. So let's cut out the old way of doing things and look to the future. Increased AI and automation are an obvious advantage, and we're seeing AI being used now in many of the IT tools that we're using in our environments, and cybersecurity tools to look for anomalous behaviors on our networks, right? So AI is for the future. Hopefully we can avoid some form of Skynet, which I think is a lot of people's concern, but we're a long way away from that sort of deep learning type AI anyway. We have, we have a number of other things I've put in on the slide in front of you that are changing healthcare. So let's look for the future, and that future will be an increased role in IT, an increased role in cybersecurity, an increased use of automation and technology, and hopefully a lot more US hospitals getting to NEHIMSS stage 7 for infram and NRAM, right? As we increasingly digitalize. So back to 2025 again, Esmond.
Yeah, so a lot of what Richard's described is around connectivity and interoperability, this kind of ubiquitous sensors that we're making available. It's a mishmash of industrial systems, medical devices, traditional IT delivery, cloud delivery, and indeed consumer level technologies. The scale of this is huge. You know, but in fairness, there's also some global spectrum to this this increasing adoption of IoT. It's actually slowed, believe it or not. We've had a lot of nation states that are, for lack of a better expression, creating some tensions at the global level. And originally, Gartner and IDC had predicted by 2020 we would have, you know, some of these systems vastly connected to create this huge interconnection, this global network. It's actually slowed. They've pushed it out by 5 years due to some of those supply chain risks, whether it was tsunamis or various hurricanes or indeed some sort of political situation. We have slowed, but it's still on the horizon. We've also since taken some of those measures in the last 3 months to increase adoption. So we've created more of that application IoT problem where we've now got chatbots, we've now got symptom bots, we've now got employees potentially checking in their temperature before they show up in the workforce. It's certainly a very, very large problem space. It's also creating a data bus. It's creating this opportunity for us to speed and be proactive, as Richard had described earlier. Cisco describes it as 1 trillion connected devices is where we're going. We're looking at the kind of vision where our hospitals are already struggling to adapt to this smart hospital concept. The number of devices in a patient's room may well dwarf the number of nurses on that floor. Richard, if we can move on. This opportunity here is to use and leverage some of this IT that we've created, you know, working off the principle that security isn't an afterthought. You know, that we're building this connectivity, we're building this interoperability, we have these integrity checks. These core components around business delivery are now IT driven. The kind of traditional physical business delivery of patient care at the bedside is now home care driven, and we're leveraging digital reality in both the actual traditional hospital delivery systems, but also some element of home care. It's kind of created this self-reinforcing, self-improving feedback system, but not without some peril. So when you think of these healthcare issues around monitoring blood pressure, heart rate, we're doing it using some of our more legacy systems that might be movable, they might be wearable, they're implantable. Now it's also some elements of consumer level technology, which isn't really built to be as robust and mature as some of our FDA requirements. The gold standard tends to be watered down. But as Richard had described earlier, some of our regulatory pressures are starting to recognize the pressures of COVID. It really remains to be seen how much that transformation will continue in that post-pandemic world. Beyond just connecting systems and making it the user experience more facile, can we also look at this Internet of Dangerous Things as being not just this huge spectrum of the potential denial of service, but, you know, allowing medical professionals to focus on the patient outcome so that they can make it more convenient and indeed not just following the same model we've been following from healthcare delivery where we're waiting for that acute care issue. We start focusing on that intervention, that apple a day, that prevention. So that medical insight and that augmented decision support is being made not just based upon the potential lucrative opportunity with connecting people to IoT devices, but also focusing on reducing the cost associated with you know, good patient care. It doesn't end at the bedside. There's a huge digital spectrum. If we can move on, please. So I mentioned earlier that there is some peril associated with it. You know, a lot of these systems aren't necessarily built around health and safety first. That gold standard is really those medical devices, but at some point, healthcare systems have struggled to implement these robust systems. The question, the challenge for us as security professionals becomes, you know, how we can do this better in this new world, this new paradigm. And some of that is some of these standards, these data buses, these device buses that we've created so that users at home can now report, interact with medical professionals. You know, we also are allowing some consumer level technologies to interface directly with some of our EHR. You know, we can prevent heart attacks if we can monitor somebody's Apple device, for instance. Unfortunately, the data does speak to the fact that, at least with respect to consumers, they're going to, you know, obsess over features rather than security and functions. We do need to become better at communicating that we need to not just enforce standards, but also vote with an element of our wallets. We've got a significant supply chain risk, as I described earlier, that's had to change in association with global reality. We don't want some of these devices showing up that potentially are compromised by default, or that introducing or insecure by default. They're introducing WannaCry. We also need to be aware that we need to also be our best advocates for our C-suite, our boards, so that when they're calculating the risks and odds and making these very revenue-driven decisions, they're incorporating these health and safety, these medical insight. That's really that transition of a CISO from being IT-driven into very business-driven. This chart, as you see in front of us, speaks to the fact that Congress is very much aware of it. Our colleagues in the medical device, the manufacturing space, are very much aware of this. We continue to see a need to advocate for better practice around our device management, our healthcare information technology. We can move on. So a lot of what we've done, this is a great reference for one way to look at what we've done over the last 3 months. And we'll talk and summarize this. We're getting towards the end. We've had to increase our focus on collaborative technologies. So our teams are now, we've extended our perimeter because our teams are now working from home. We've had to focus on how to get that up and running. We've created these constraints around VPN and bandwidth. We've educated our consumers as to how to best operate in that environment. And as Richard mentioned, we're facing the reality that our medical professionals now can be a little bit more productive associated with the adoption of these collaborative technologies, whether it's Zoom or Teams or these other kinds of ones. The patient experience is pretty good. We've also had to focus on some of our facility management. We've lost a lot of revenue associated with these elective procedures, as Richard had mentioned earlier. Whether those revenue sources include some element of parking or dining services, we've lost some revenue. And sorry about that. As much as these technologies are increasing our patient outcome, we also need to figure out how to how to make sure that we can leverage. The third element of this is the cloud, the scaling that we've done. Can these solutions overcome some of the hurdles we've had in deploying and maintaining technology? We've all had the policies, we've all had the educational prerogative. Now we need to be consistent. We need to focus on the basics because we've lost some revenue and we're being asked by our colleagues at the C-suite to do this. So as we've accelerated the curve on the digital transformation and adopted these technologies, what have we had to cut? What have we had to figure out that we can become more efficient on? And the data analytics is a huge element of what you've heard us talk about today. Can we focus on not just making the experience better for the patient and for the physician, the clinician, but now starts to mine that data, now start to focus on augmented intelligence, artificial intelligence, as Richard had described earlier. If we can move on.
You can talk to this one, Esmond. I was going to say.
Go ahead.
I was going to say. So, one of the big issues of, or one of the consequences of the change within the technology that we're applying to healthcare is the growth of medical devices and other healthcare IoT devices in our hospitals. They far outnumber traditional IT systems, workstations, laptops, cows, wows, carts, whatever you want to call them, that we use across our hospitals, including everything inside the data center. They already outnumber nurses in most hospital systems. And we're talking everything here from, your big iron devices, X-ray, CT, PET scanners, right the way through to blood gas analyzers, to patient telemetry systems, nurse call systems, to network connected infusion pumps and a heap of other equipment that resides in the lab, right the way down to your Pyxis cabinets and everything else. These are all network connected by and large, and they all pose a very real and present danger to modern day healthcare. And this chart here, which came from Semantic, it's last year's data, actually 2018's data. Unfortunately, it's published last year. But it shows that there is a concerted effort by one part of the world to exploit this healthcare IoT technology across our hospital systems. And this figure, although I haven't seen anything official, is probably raising at an exponential rate today. Certainly, China has been extremely aggressive in terms of its attacks against these types of devices, and we've seen them in, bots for denial of service, Mirai, for example, and various other exploits that are being used to attack home routers and CCTV cameras. And in fact, I like to say that several years ago, I was involved in a cyber forensic investigation of a hospital system that was attacked by its own cheap CCTV cameras that it put in to monitor its patient rooms and hallways and doorways into the system that hadn't been secured adequately. So this is a growing threat vector. It's a growing area of concern, and it's one that by and large hospitals in the US haven't addressed yet. So on to our penultimate slides, I believe, here, Esmond. I know we're running short on time.
Yep. So I'll try and motor mouth through this. As Richard indicated, there's increased global tension around that supply chain. We need to make sure that we continue to advocate for best practice and standards around that. We're also dealing with the fact that the relative sophistication of our adversaries has increased significantly. They have benefited greatly from the leaks from Edward Snowden and the NSA Equation Group. Phishing has spiked around the COVID threat. We're seeing a 20 to 30% increase in phishing. They're still continuing to advocate for ransomware. They're hitting us with it wasn't just the hospital that Richard had mentioned. We also had one of our the industry's stalwarts. Cognizant was attacked 2 weeks ago with Maze ransomware. These days, the ransomware actors don't just encrypt your infrastructure. They in some instances do a better job encrypting than the good guys do. But they're also starting to exfiltrate some data, so you don't know what left, which was one of the guidances from OCR was we need to focus on making sure that the data didn't leave our environments. The bad guys are already ahead of us on that one. Their jobs are a little bit easier. We've had this transition to more of that digital workforce, also creating some problems because some of our legacy VPN solutions are inherently insecure. We've had to scale them out. Have we scaled out inappropriately? We've yet to determine. The FBI is alerting to bad guys, whether it's nation states or otherwise, hiding in plain sight and attacking some of these Pulse VPN systems and such that are out there. Some of our Citrix ADCs that we deployed. The last 3 or 4 months, we're also dealing with some of the Iranian threat actors hiding in plain sight as well. But also we're dealing with now those users are at home. What's the risk associated with their Amazon Alexas, their home routers? Because the bad guys are going after them. They're scanning quote unquote Comcast and RCN. But realistically speaking, what they're doing is they're potentially coming in through a back door. Has your device hygiene increased significantly enough to encompass that threat? If you put a block on a phishing email and the user on your on-premise infrastructure can't get to it, well, now they're going to send it to your user's Hotmail. They're going to go after your user's Yahoo or Gmail. And did your controls follow the users? And if we go to the next slide, this is kind of the takeaways, guys. We have some work to do. As much as there's some element of fear-mongering or scaremongering with what you've heard today, we have done tremendous things. As Richard had mentioned, Zero Trust, he does work for one of those companies and he probably doesn't want to mention it, but biomed security is a huge element of what we're trying to do here. Taking that external user and applying those controls, not just externally, but also internally is a huge opportunity. Taking that huge collaboration and communication and that cloud scaling that we just did, and making sure, number one, that we have those baseline controls around the content inspection, DLP, hygiene, threat management, that we're still continuing to patch. Those are table stakes. We got to do that. It just got a little bit more complicated. We continue to need to educate our users. AOCR has allowed some expediency around what vendors you can use and what information you can disclose, but we will all have created, I would imagine, some vendor backlog that we need to go through. We will all have pinned some of our projects that weren't critical to, you know, patient health and safety and or revenue, and we're going to go revisit those. So some of those strategic efforts that were more longer term, we still need to execute on those. We've got to go back to those. IoT, I will guess, will be one of those. Now that IT and OT is critical to the delivery of the business, whether it's on-prem or in the home, we need to revisit that and capitalize on the fact that security was just granted a huge opportunity to have a seat to talk about how we adjust, how we transform. It remains to be seen what the cleanup looks like. I do foresee that there will have been some of that change occurred without some InfoSec rigor. There will be some shadow IT cleanup. It remains to be seen what our regulator will do. It remains to be seen if they will continue to relax some of these obligations. I am doubtful. But right now, that's the summary. We've got about 5 minutes, guys. That one slide kind of summarized what you've just heard Richard and I talk about for the last 55 minutes. So questions, please.
Great. And these slides will... Go ahead. Go ahead, Eliza.
Go ahead. We do have a few questions that have come through on the chat. The first one is from Scott. He's asking, how do we provide telehealth for those who don't have or know how to use the requisite technologies, such as a PC, a tablet, or have internet access?
Richard, do you want me to take that one?
Yeah, if you would, Esmond.
Okay, so what the OCR guidance was around the use of public systems. So they're discouraging those systems, number one, that you haven't submitted for assessment and rigor. Hopefully you've been able to accelerate these existing collaborative measures you already have in play. But OCR did indicate that some of those more consumer-driven systems like FaceTime and Google Hangouts / Google Duo are acceptable. So you kind of need to establish a tiering system. The preference is vastly that your clinicians and your users are using your corporate endorsed standards that are subject to BAA and your security control, your DLPs, your threat prevention. But in the scenario where they can't use those, FaceTime and Google Duo are allowed, as I understand the OCR guidance.
Yeah, that's my understanding as well. Eliza?
So the next, yes, go ahead.
No, I was going to say next one. Yep.
Cybersecurity typically, I'm sorry. Can you speak towards the CMS rule of interoperability and if it's going to be implemented as expected?
Sounds like another one for you, Esmond, there.
Yeah, so I described throughout this deck on interoperability, we need to face reality that the EPIC is about 80, certainly somewhere to 60 to 80% of systems in certainly the US, and the remainder is Cerner is a huge federal tenant, and then you've got some of the other systems, whether it's Athena or McKesson or these other kinds of ones. And so interoperability, the TEFIC and these other kinds of groups that have established interoperability standards, the health information exchanges continue to exist. We were allowed some leeway or forbearance around sharing with public authorities. I think it continues to be a necessity. Those standards exist. I think it's going to be real interesting, and I'm interested around kind of that smart on fire, that Apple Health Kit one, where if meaningful use continues, I don't know if we're going to get an extension for this year. I'm certainly interested to see if we can continue to focus on that very patient-centric user experience, so the user can get whatever application they want, and then they can aggregate whatever health systems that they work with or interface with in that mobile app. I certainly think, yes, I'd be interested to see if our regulator allows or extends meaningful use. They did just add, I think, 3.7 million, some grants associated with telemedicine, telehealth. So I think they need to revisit high tech. I didn't really touch upon that in the presentation, but I think they should encourage further stimulus around what we just went through, because we are revenue constrained. And, I do think I'd like to see some action from the government to continue that and continue that acceleration that we just went through. Richard, anything to add?
No, my understanding from talking to folks in OCR is that they are expecting extensions to meaningful use, and also for a lot of the exemptions to continue throughout most of the rest of the year and possibly into next year. That's not official, but that's what they're telling me.
Okay. Eliza, we've got 1 minute. Yep.
Yeah, we have two more questions. Maybe we can try to get to them. One is, it has been predicted that many physician practices will end up going out of business due to COVID. So suggested next steps for practices to meet the changes caused by COVID if they plan on surviving.
The first, I'll chime in on that one if you like. I said the first is really the adoption of telehealth, telemedicine technology. A lot of physician practices have been historically technology averse. A lot of senior physicians or more elderly physicians have not embraced technology in the way that the community as a whole has. And I think we're seeing a movement towards the adoption of and integration of telehealth technologies provided by third parties, so that physicians can continue to see their patients, but do so from a more a safer distance by telehealth. Esmond?
Yeah, I would agree. It's kind of strategic. You need to align yourself. If you're now that IT is critical and you're not an IT shop, you need to find out how to partner with some of your strategic vendors. Some of that vendor supply chain management has been a mixed blessing. I see in the chat window somebody's offering help. Right now, I feel sometimes I want to feed some of my vendors to Carol Baskin's Tigers. It's been a mixed blessing. I certainly encourage further alignment. If you don't have an IT focus, it's not critical to you, you're going to have to align yourself with someone for who it is.
Yeah, it's a market adoption, right, or a market adaptation, right? And there's a lot of talk about, are a lot of the big box stores that we see in our shopping malls, are they going to go permanently out of business? I would suggest they might well do, because they haven't adapted to the times. Right? And we in healthcare need to adapt to what our consumers are asking for, rather than continuing or perpetuating the legacy model.
But I do think that there will be an aftermarket, so the market will adapt and adjust. And I think, if I use the analogy earlier of Amazon, you're going to have Etsy type stores. You're going to have these kind of gig economy kind of things increase.
Yeah.
So being considerate of time, I just want to go ahead and wrap up and thank Richard and Esmond for presenting today to the New England HIMSS members today. The survey, the CP HIMSS letter, along with the presentation handouts and a recording will be sent to the registered attendees for today's call. So please take a minute to fill out that survey and let the New England HIMSS Speaker Committee know what kind of topics you would like to continue these webinars. And once again, thank you guys for joining us today, and I hope everyone stays safe and well.
Well, thank you on behalf of Esmond and myself. Thank you for inviting us to come and speak with you. And I'm sorry we weren't able to do it in person.
Be well. Thank you so much.
Thank you.
Thank you, guys.